The following podcast is part of a certified educational activity titled Moving Toward the Future in MS Management, What's the Latest on BTK Inhibition? Access the entire activity and complete the post-test at peerreview.com/WGE860. Downloadable slides are also available.
Hello, everyone. My name is Jiwon Oh, and I'm an MS neurologist from St. Michael's Hospital at the University of Toronto in Canada. Welcome to this educational activity on Bruton's tyrosine kinase inhibitors and multiple sclerosis. I think many of you have heard quite a bit about Bruton's tyrosine kinase inhibitors, or BTKIs, in MS. And it probably is not an exaggeration to say that these molecules are the most intensely studied experimental molecules in MS at the current time period. And you might be wondering why there is so much interest and excitement about these molecules. And this is because there are many potential advantages of using BTKIs in MS treatment over what we currently have. Many studies over the years have shown that chronic neuroinflammation contributes to this smoldering disability that we see in both relapsing and progressive forms of MS. So across the entire spectrum of MS. And we know that this chronic smoldering inflammation is driven by B cells as well as microglia in the central nervous system. And it turns out BTKIs have a profound effect in regulating B cells as well as activated microglia in the central nervous system. So it makes it a logical therapeutic target, not just in MS, but many other autoimmune diseases like lupus and rheumatoid arthritis as well. In addition, many of the existing MS therapies that we have act primarily outside the central nervous system, so they're very good at modulating peripherally mediated inflammation, which we know is a major component that drives MS pathophysiology. However, there is a whole another central compartmentalized smoldering inflammation that we know is responsible also for a significant amount of MS pathophysiology, which results in progression over time, which is ultimately what we want to prevent. And BTKIs, unlike many of the other therapies that we currently use in MS clinical practice, many of them have demonstrated an excellent ability to cross the blood-brain barrier and therefore reach therapeutic concentrations in the CNS, which means that they likely are able to have a beneficial effect, not just in the periphery, but also in these central compartmentalized processes, which is a huge unmet need in the therapeutic field. This is a slide just summarizing, again, the rationale of BTK inhibition in MS. We know that BTK is an enzyme that is responsible for the modulation and proliferation of B cells, as well as activated microglia within the central nervous system. And therefore, when you inhibit BTK, it has the potential to decrease B cell maturation and proliferation, as well as the downstream functions of B cells, which include autoantibody production as well as cytokine secretion. With microglia in the central nervous system, modulating the function of microglia via BTK inhibition has the potential to decrease microglial activation and downstream effects of microglial activation, which include the proliferation of pro-inflammatory cytokines, which are listed here. So, BTK inhibition, does have some overlap with the anti-CD20 agents, which are a class of molecule that are very commonly used currently in the MS treatment landscape. We know that the anti-CD20 monoclonal antibodies are probably, at least in relapsing MS, one of the most highly effective drugs, and therefore it explains why they are so commonly used. And these therapies mainly target B cells and essentially cause profound B cell depletion. And we know that there are very beneficial effects on relapse biology-related clinical and MRI measures. Because BTK inhibition can modulate B cells, we also know that there likely is a decrease in B cells, which results in likely some of these beneficial effects that we've seen with anti-CD20 monoclonal antibodies. However, there are distinct differences between BTKIs and anti-CD20 monoclonal antibodies in that We know that the anti-CD20 monoclonal antibodies profoundly deplete B cells, and therefore they are immunosuppressive agents. However, BTK inhibitors may not wipe out all B cells and may therefore target only a subset of likely autoreactive B cells, and so it is possible that they may not have the same issues with as much profound immunosuppression as we have seen with the anti-CD20 monoclonal antibodies. The issue with immunosuppression and anti-CD20 agents was very clearly illustrated during the COVID-19 pandemic, when evidence from around the world pointed to the fact that being treated with an anti-CD20 agent was a risk factor for developing severe COVID infection. This figure here illustrates the increased risk of hospitalization related to COVID-19 with the use of ocrelizumab and rituximab, which, as you know, are commonly used anti-CD20 agents in MS. In addition, as with many of the other therapies that we use in MS, many which are also immunosuppressive agents, generally infections are increased with the use of different therapies, including anti-CD20 agents. So we're not just talking about COVID, but other infections. And so this issue with chronic immunosuppression becomes a relevant one with many of the therapies that we currently use in MS. And again, because BTKIs may target specific sets of immune cells, it is possible that it may not cause as profound immunosuppressive effects as some of the other disease-modifying treatments that we currently use in MS. So, with that background, I think it's very clear why there is so much interest in BTKIs in MS. And as a result, there's many different BTKIs currently being evaluated in MS clinical trials. And this is a table that summarizes all of the different BTKIs that are currently being tested, which include evobrutinib, tolebrutinib, as well as fenebrutinib, and remibrutinib or relabrutinib, as well as a molecule that for now is being called BIB91. Today we're going to focus on phase 2 clinical trial results from tolebrutinib as well as evobrutinib. And the reason why we're doing this is because phase 2 trial data are really available only for these two BTKIs. So I'm just going to start with evobrutinib, which was the first BTKI that reported results from a phase 2 clinical trial. Very briefly, the study design looked like this, where various doses of evobrutinib were evaluated versus placebo, and there was also an active control arm of dimethyl fumarate. The initial blinded treatment period lasted for 24 weeks, and then there was a blinded extension of 24 weeks where people continued on their current dose of evobrutinib, except for the placebo arm in the initial 24-week trial. They were transitioned to the lowest dose of evobrutinib at 25 milligrams once a day. After that 24-week blinded extension of the initial phase 2 clinical trial, there was a safety follow-up of 4 weeks and then an open label extension where initially patients were treated with evobrutinib at 75 milligrams once a day and then later transitioned to 75 milligrams twice a day, which is the dose that was eventually chosen for the phase 3 clinical trials. The primary endpoint, as with most phase 2 clinical trials of relapsing MS, was the number of gadolinium enhancing lesions, as well as various other MRI measures. And clinical endpoints, including annualized relapse rate, as well as EDSS scores, were evaluated. But it's important to note that, obviously, because this is a phase 2 clinical trial, it was not designed to evaluate the clinical endpoints. So in terms of the results from the evobrutinib phase 2 study, evobrutinib at 75 milligrams once a day did meet the primary endpoint of a significant reduction in gadolinium enhancing lesions versus placebo. The dose of 75 milligrams twice a day showed a trend towards a difference versus placebo. When you look at safety, the rates of treatment emergent adverse events, including grade 3 and serious AEs, were comparable between most of the evobrutinib treatment arms, including the 25 and 75 milligrams once a day versus placebo, but was slightly higher with evobrutinib at 75 milligrams twice a day, and this was driven by asymptomatic increases in liver enzymes, which is something that is seen with many of the BTKIs that are currently being evaluated in the MS field. There was a dose-response relationship that was observed with the primary endpoint of gadolinium-enhancing lesions as well. When you look at some of the clinical endpoints, including annualized relapse rate, as you can see numerically, there was what looked like a much lower annualized relapse rate between weeks 0 to 24, as well as between weeks 0 to 48 with the higher doses of evobrutinib. But again, because this was a phase 2 trial that was not powered to evaluate these clinical endpoints, this difference was not statistically significant. This is a table just summarizing adverse events. And so as we talked about, as you can see, generally, the incidence of serious adverse events was similar between when you compare placebo as well as evobrutinib at the lower doses, but was slightly higher with evobrutinib at the 75 milligrams twice a day dose. And this was primarily driven by an increase in liver enzymes, as you can see here. Moving on, there have been additional analyses done using the phase 2 clinical trial data as well as extension data. And one analysis of significant interest is looking at the effect of evobrutinib on slowly evolving or expanding lesions or cells in this clinical trial. And the reason why this endpoint is of high interest in the MS field is because it is thought that slowly evolving or expanding lesions may capture chronic active lesions, which captures a component of that CNS compartmentalized smoldering neuroinflammation that I referred to earlier. And the reason why we focus so much on this is because it's thought that chronic active lesions are one of the primary drivers of this smoldering pathophysiology that we think is responsible for the progression that we see across the spectrum of MS. Now, as with any MRI measures, cells are not perfect and likely do not capture all chronic active lesions. There are all of these methodologic issues that the field is questioning, including, how long do you monitor cells for and all of these other things. Nonetheless, it's a very useful measure because it likely does capture at least a component of these chronic active lesions that we're so interested in. So in this analysis, when the investigators looked at the effect of evobrutinib at higher doses, so evobrutinib at 75 milligrams once a day or twice a day, as you can see, these higher doses of evobrutinib did seem to lower cell volume in comparison to the lower doses of evobrutinib as well as placebo. Now, this was just an analysis that took place over a relatively short time period of 24 weeks. Nonetheless, it's noteworthy because it does look like, again, that evobrutinib, at least at the highest dose, did seem to have a significant effect on reducing cells, which again, we think may capture a component of chronic active inflammation, which again is a real focus in the field because this is thought to be the pathophysiologic substrate of progression in MS. Moving on, evobrutinib, after the initial phase 2 clinical trial, so the blinded phase consisted of 24 weeks, then there was an open label phase of 24 weeks, then an open label extension that has continued on now for 2.5 years. The 2.5 year extension data were recently reported. And as you can see, the majority of participants from the 48-week double-blind phase 2 trial entered the open label extension. And the majority, so 75%, had completed the 144 weeks of open label extension treatment at the time of this data analysis. What's reassuring is that the main efficacy endpoints that were evaluated in the initial phase 2 trial, so the total number of gadolinium enhancing lesions, mean volume of T2 lesions, all remained relatively low when patients switched to the 75 milligrams twice a day dose, which again is the dose that has been selected to be used in the phase 3 clinical trials of evobrutinib. In addition, when we look at clinical endpoints, and again, keep in mind that these studies were not powered to evaluate these endpoints, nonetheless, it's useful to look at them over time to see how patients do. Overall, the EDSS scores remain stable, and the annualized relapse rate also remained low in people after they switched to the 75 milligrams twice a day arm or continued on the 75 milligram twice a day arm. So overall, the extension data, which extends now up to 2.5 years, are relatively reassuring because there have not been any new safety signals, and the clinical endpoints and MRI endpoints seem to be relatively stable, at least with the highest dose of evobrutinib. So we'll look forward to hearing what the results of the phase 3 clinical trial look like. Moving on. Tolebrutinib is the second BTKI in the MS field that has made it farthest along in clinical development, and also has a completed phase 2 clinical trial, as well as an extension study that now extends out to the 2-year mark. So the tolebrutinib phase 2 clinical trial looked like this, and I think it's worth pausing on this study design for a moment because it's a very interesting and efficient study design that allowed the evaluation of 4 different doses of tolebrutinib over a pretty short time period of 16 weeks, as you can see with the double-blind phase 2 clinical trial that you see illustrated on the left here. After the initial 16-week double-blind placebo-controlled clinical trial, where there was both a placebo run-in and a run-out, there was a bit of a gap period related to mainly administrative delays, and then patients entered long-term extension Part A, where they continued on the same dose of tolebrutinib that they had been on in the double-blind period. And then when the dose of 60 milligrams per day was decided on for the phase 3 clinical development program, all patients were then transitioned on to the highest dose of 60 milligrams per day. So with tolebrutinib, in the initial 16-week phase 2 clinical trial, it did meet its primary endpoint of a reduction in gadolinium enhancing lesions with the highest dose at 60 milligrams once a day. In addition, numerically, there was a decrease in the clinical measures, including annualized relapse rate. And in terms of safety, in terms of a class effect, besides what was expected to be seen, including an elevation in liver enzymes, as well as nasal pharyngitis and upper respiratory tract infection, there weren't any other AEs of major concern observed. The tolebrutinib phase 2 trial has now been, all of the patients were offered, and the vast majority of them continued on in the long-term extension study. And we now have up to 2-year safety and clinical efficacy data from this long-term extension study that were presented at ECTRIMS. So what's reassuring is that there are no new safety signals in the phase 2 extension. Up to week 96. The most common adverse events are listed here, and the most common AE was by far COVID-19, and the majority of cases were mild and moderate, and all patients recovered. When we looked at efficacy outcomes, including annualized relapse rate and disability change from baseline, reassuringly, the annualized relapse rate remained low in those who had been treated with the highest dose of tolebrutinib at 60 milligrams for 8 weeks or longer, and EDSS scores generally remained the same. So all of these findings are relatively reassuring, and it will be of interest to see what the phase 3 clinical trial results show. Moving on, when we look at MRI data from the long-term extension study of tolebrutinib, there was also a slowly evolving or expanding lesion volume analysis that was done at week 96. And as you can see, those who were on tolebrutinib at 60 milligrams and 60 milligrams throughout the long-term extension study appeared to have the lowest volume of slowly evolving or expanding lesions. These results are interesting, but again, because we're trying to understand in terms of monitoring cells, what is the ideal duration over which you monitor them, what should be used as the baseline reference point. These data are interesting, but definitely not definitive. And this statement applies to the discussion that we had with cell volumes with evobrutinib data as well. Again, of high interest because likely cells capture a component of chronic active lesions. However, it's difficult to interpret these data at the current time just because there are many questions about how to best evaluate cells over time so that it reflects an effect on chronic active or smoldering inflammation as we hope it does. In addition, there's another imaging measure called paramagnetic rim lesions that are obtained by using appropriate susceptibility base sequences. And these measures are also of high interest in the field because it's thought that paramagnetic rim lesions also detect chronic active lesions, which again are of high interest. Over the time period that these patients were followed in the tolebrutinib phase 2 long-term extension, there wasn't a lot of change in paramagnetic rim lesions. 2 patients who had a paramagnetic rim lesion at baseline no longer had them at week 96. And there were 3 patients who had between 1 to 3 additional paramagnetic rim lesions develop at week 96. And notably, none of these patients were in the 60 milligram arm. Again, interesting. Obviously, we'll need additional information to form better conclusions about what these data mean. But it will be interesting and informative to the field to continue to follow these patients because it will be noteworthy if there is a clear effect on paramagnetic rim lesions as well as slowly evolving or expanding lesions, with the caveat that we're still trying to understand how to best use these measures. And reassuringly, those who were deemed to have highly active disease at study onset also maintained a low annualized relapse rate and low gadolinium lesion count and stable EDSS scores, which is additional information that is reassuring. We did talk about evobrutinib and tolebrutinib's phase 2 trials in detail, and this is because these are the only 2 BTKIs that have completed phase 2 clinical trials in people with MS. Both evobrutinib and tolebrutinib are being studied in phase 3 clinical trials. Evobrutinib is being evaluated in 2 phase 3 clinical trials of relapsing MS, and hopefully those study results will be available in the next year or 2. Tolebrutinib is being evaluated in a very extensive clinical development program. In relapsing MS, there are 2 phase 3 clinical trials, but there also is a dedicated trial evaluating tolebrutinib in primary progressive MS as well as non-active secondary progressive MS. So amongst the BTKIs, it is the most extensive clinical development program, as you can see in this table here. Fenebrutinib is another BTKI that is being evaluated in 3 different clinical trials, 2 in relapsing MS and 1 dedicated to primary progressive MS. And notably, in the FENtrepid trial, fenebrutinib is being evaluated versus an active comparator of ocrelizumab, which is also quite unique. Finally, the next BTKI that is furthest along in clinical development in the MS world is remibrutinib, that is currently being evaluated in 2 trials of relapsing MS, and those studies are currently still recruiting. So in terms of with this very busy experimental landscape, what does this all mean for the future of using BTKIs in MS care? I don't think there really ever has been a time where so many different molecules, technically part of the same class of drug or family of drug, have been studied at such a similar time frame. So I think some of the questions that come up as clinicians are, there's so many different trials evaluating different BTKIs, and is there a meaningful difference among molecules in this class? And if there is a meaningful difference, what does it mean clinically? Are there differences in efficacy? Are there differences in safety? And I think, we can theorize a lot based on what we know about the pharmacologic properties of many of these molecules. But in the end, the proof will be in the pudding. And this is because from a pharmacologic standpoint, there actually are many differences between these BTKIs. They do all belong to the same class of molecule in that they are inhibitors of BTK. However, there are likely differences. Some of the differences may be subtle, but whether that means that it will have a meaningful difference clinically from an efficacy or safety standpoint, I think time will tell. So there are differences in terms of CNS penetration of some of these BTKIs, their selectivity in terms of how much of an off-target effect that they have, because BTKIs are obviously, BTK is not an enzyme only expressed in B cells and microglia, which is what we focused on. It's an enzyme that's actually expressed pretty widely, and so the selectivity may be a key piece in terms of determining safety. There's differences in how these BTKIs bind to their target, whether it's reversible or non-reversible, whether the interaction is covalent or non-covalent. And in terms of its domain target, there are also differences. So, whether these differences will result in a meaningful clinical difference, it's not clear, but I think it's something very important to keep in mind as we wait to hear the results of these phase 3 clinical trials. So the question of, how will we use BTK inhibitors in clinical practice is a very relevant one. As you heard from that very busy table that I presented to you, BTKIs are being studied across a wide spectrum of MS. Some of the BTKIs have a much more comprehensive clinical development program. So it may be that different BTKIs may be suitable for different stages of disease, but of course we'll have to see based on what the phase 3 clinical trial results show. The question of where BTKIs may be used in the disease course is a relevant one. And again, I think all of this will depend on what we see in the clinical trials, as well as how the field evolves in terms of what we think about MS disease subtypes, how we classify MS, and what sort of molecules are most useful and what pathophysiologic processes are most useful to target at different stages of disease when people probably have different amounts of relapse biology versus progressive biology. In addition, safety comes up, and again, this likely will have to do with the selectivity of different BTKIs. And so I think based on what we see in the phase 3 clinical trials and long-term extensions of safety, we'll have to make decisions about what sort of patients are most suitable for different BTKIs. And as many of you know, just wanted to make a quick note of the fact that there has been a partial clinical hold of recruitment for tolebrutinib clinical trials in the United States. And this is because of reports of isolated liver injury among some study participants in the phase 3 clinical development program. And this led the FDA to ask for a pause in recruitment for the tolebrutinib studies starting in June of 2022, so just a few months ago. Of note, most of the affected patients had comorbidities that are known to predispose them to drug-induced liver injuries, and the elevations in liver enzymes were reversible after drug discontinuation. It's not very clear whether this is an issue related to tolebrutinib alone. What is clear, though, is from the safety data that we have of different BTKIs, we do know that liver enzyme elevation is a risk with all of the BTKIs. So it is possible that this is likely a class effect, and the fact that tolebrutinib has a much larger clinical development program may have resulted in just larger numbers of people being treated and some having more severe drug-induced liver injury. But obviously, we look forward to hearing more results about these patients and what the final decision is about the tolebrutinib program. There were some interesting abstracts that were presented on BTK inhibitors at the very recent ECTRIMS Congress, which just took place in Amsterdam. This question of disease rebound after drug discontinuation is a relevant one because of the field's experience with S1P receptor agonists as well as natalizumab. And so the phase 2 clinical trial design with the placebo wash-in and wash-out period allowed for at least a brief assessment of whether there is rebound in the 4 weeks after drug discontinuation. And in this preliminary analysis, there was no suggestion of any drug discontinuation related rebound disease activity with tolebrutinib, which is reassuring, but obviously longer observation periods are needed to validate these findings. In one interesting in vitro trial that assessed selectivity amongst many of the BTKIs, remibrutinib, fenebrutinib, evobrutinib, and tolebrutinib, as well as orelabrutinib. So almost all of the BTKIs that we discussed are being evaluated in MS. The investigators ranked remibrutinib as having the least off-target binding, which is interesting information to note. As we discussed, there are many pharmacologic differences amongst the BTKIs being studied, and selectivity may have to do with ultimate safety profile, but again, we'll obviously have to see based on what we see in clinical trial results. Finally, a very interesting study by Dybowski et al. Looked at an animal model of MS, EAE, which is a model we're all pretty familiar with. And they found that when an anti-CD20 agent is followed by a BTK inhibitor, there seemed to be significant clinical benefit in EAE. So in this study, mice received a number of doses of anti-CD20 monoclonal antibody and then a number of doses of evobrutinib before being immunized with a B-cell mediated model of EAE. And what the investigators found was that the anti-CD20 agent had a mild benefit on clinical EAE, but disease severity was diminished significantly when you added on evobrutinib after the anti-CD20 agent. And it was postulated that this is because B-cell maturation was blocked and the reappearance of mature naive B cells, as well as what are likely pathogenic memory B cells, were delayed by the addition of the BTKI. Now, obviously, these are preclinical studies, but this is of interest because this suggests that the sequential combination of BTK inhibition with B-cell depletion may be beneficial from an EAE standpoint. And obviously, the studies need to be done in humans, but this is potentially something that could be thought about when thinking about how these agents, if they prove to be effective in phase 3 clinical trials of MS, could be used with respect to sequencing in MS clinical care. So with that, I hope that I've been able to give you an idea of BTKIs in general, why there's so much excitement on using them, because they have a role in B cells and microglia and MS pathophysiology, and why it makes to leverage the therapeutic potential of BTK inhibition in MS. I hope I've been able to summarize some of the promising long-term data from phase 2 trials that justify all of these phase 3 clinical trials of these various agents. And then, the results of the phase 3 trials will help us understand how each BTK inhibitor needs to be evaluated, how they can be used in clinical practice, and their heterogeneity should also caution us against considering them interchangeable drugs. So with that, this concludes our educational activity, and I'd like to thank you for participating.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/WGE860. This activity is supported by an educational grant from Sanofi.